Hello, it's Dr. Garrett Pohlman, host of the Prostate Health Podcast. Today we'll be talking about the new paradigm shift in how we treat men with an enlarged prostate. I'm very excited to have on as our guest today, urologist Dr. Steve Gange. So stay tuned.
So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast.
Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. Joining us today on the Prostate Health Podcast is urologist Dr. Stephen Gange. He has over 25 years of clinical and research experience. He has developed a particular expertise in men's health urology, emphasizing in minimally invasive procedures. He was the first urologist in North America to perform the UroLift procedure for BPH, or Benign Prostatic Hyperplasia, or an enlarged prostate, and was the first in the world to perform UroLift under local anesthesia. He enjoys teaching urologists and proctoring procedures all across North America. He has lectured on BPH and UroLift at several national professional meetings and has co-authored several of the pivotal UroLift papers in the urology literature. Dr. Gange, welcome to the Prostate Health Podcast.
Thank you, Dr. Pohlman. It's a real pleasure. I'm excited to be here.
So we've already covered in a previous episode really what is BPH or an enlarged prostate. So today we'll be getting into the treatment options for an enlarged prostate and how we are really seeing a shift in the paradigm of how BPH is treated. So Dr. Gange, before medications were introduced in the 1990s for an enlarged prostate, what were some of the available options for treatment of an enlarged prostate?
Depends how far you want to go back. We literally can go back 3,000 years and learn about the placement of bizarre tubular structures in the urethra, catheters, made of a variety of vegetables and eventually metals and so forth. And that was all a result or a requirement to help someone urinate whose prostate was causing obstruction. And those folks died early. Some of them died because of this condition. There was no need for actual prostate procedures, nor was there any expertise. In the Middle Ages, popularized because of the presence of bladder stones, there was a group of doctors, I guess you can loosely call them doctors, who perform a variety of interesting and scary and often lethal, procedures to try to extract stones from the urinary tract. And these stones, much like the need for the catheter, are a result of urine not passing freely from the urinary tract, and typically because of the prostate. Finally, in the 1800s, some ambitious surgeons started removing prostate tissue, first through the abdomen, later through the space that we sit on called the perineum. That brings us to the early 1900s. And then in about the 1930s, a few folks were collaborative and invented a procedure called the TURP, the transurethral resection of the prostate, in which, through an instrument, a scope, tissue is removed and a cavity is established where there was previously an obstruction. And that went through several variations on technology, but ultimately was the mainstay of treatment for BPH, as you described, benign prostatic hyperplasia. In fact, in the 1960s and 1970s, it was the number one surgery in America because, as mentioned, BPH is so prevalent and we had nothing else. At least we got away from those strange little tubes. By now we've had rubber and latex and those went better, and we weren't taking stones out of people's bladders. We were actually addressing the problem. So in many respects, that procedure was pivotal. It defined our specialty as urologists. Only us, no one else could do these things. And we had the capability of really turning around the disease state by opening up this channel until the 90s when the drugs came. So we were doing mostly TURPs. Bigger prostates were managed in those years with open prostatectomies. Those procedures developed in the 1800s, early 1900s. Things changed at the time of the introduction of medications.
Can you tell our listeners a little bit more about what's involved with the TURP procedure or the transurethral resection of prostate?
Absolutely. An ingenious idea to carve the prostate sort of from the inside out, leaving as if you were removing the flesh of an apple, but leaving the skin behind. And this was all done through a telescope passed through the opening of the penis, done with light to see and electricity to cauterize. And these pieces of tissue were removed and the side effects. You can imagine, even if you don't have any medical background, that carving into an organ could create some bleeding. And this continues even now to be one of the biggest drawbacks of this operation. Also, once we've created that defect, it's a raw surface, and that raw surface needs to heal. So a catheter, not the old school catheters, the newer catheters, a catheter is placed usually for a day or several days. But then there's some downstream concerns that are real. Scar tissue can form, and that scar tissue can require additional surgery. And the sexual consequences, I think, are the biggest concern of men who are getting into this part of their lives these days. So an almost certain loss of ejaculation, so no more semen is expelled at the time of orgasm, and about a 10% risk of loss of erections, probably related to the fact that we're using electricity so close to these delicate nerves that transmit those signals to the penis.
So really in the 1990s, we saw the first paradigm shift in the management of BPH. Men, when presented with the option of big surgery or a pill, many chose the pill. So this is about the time you were finishing residency training. So you've certainly experienced this wave of treatment for BPH, right?
Absolutely.
And so can you give our listeners a bit of an overview of some of the common medications that have been used and are still used and kind of how they work in managing this enlarged prostate?
So it helps, I think, to understand what the prostate is comprised of. There are muscular fibers, and then there are some glandular fibers or glandular areas. And those glands produce semen. They happen to also produce the PSA that we all get talking about, and I'm sure you'll have some discussion around. Because there are dual components, sometimes, approaches are used to address both. And in some other cases, addressing just the muscular or the glandular makes some sense. And the drugs that were in development in the 90s were designed to first, in the case of these drugs called alpha blockers, relax the muscle tissue. And then later, a group of compounds called the 5-alpha reductase inhibitors would shrink those glands. And in some cases, and in some studies, this proved to be the case, combining those two therapies, gave you the most bang for the buck and really addressed the obstruction short of surgery. It addressed it pretty well.
Now, you and I have certainly seen some of the problems, though, with this medication first paradigm, and was going to see if you could talk a little bit more about some of these issues.
Yeah. And just taking a step back, it's interesting how we learn about side effects of medications. Sometimes we learn about them early on in clinical trials, and in other cases, it can take decades to appreciate some of the downsides of the decisions that were made. And so what we know about, say, the alpha blockers like Flomax, which is now tamsulosin generically, little stuffy nose, headache, dizziness, generally feeling kind of a lack of energy, and then some sexual side effects. Here we go again. And in this case, it's mostly a loss of ejaculation because the muscle fibers now are relaxed and the semen takes the path of least resistance, may end up in the bladder. Those are some, of the well-known side effects of alpha blockers. And yet they're probably the most used compounds. And then in the other arena, the 5-alpha reductase inhibitors, it's kind of interesting there too. Some of these side effects are emerging. I don't think the jury is in on all these things. The things that bother patients tend to, again, be sexual. Specifically, now that the glands have sort of dried up, there's no semen anymore. It doesn't come out at all. Erectile dysfunction is a real consideration for patients on medication, this class of medications.
Dr. Gange, next I want to get into and chat about the next and now new paradigm shift in the management of BPH. But first, we'll take a quick break for our sponsor, and we'll be right back.
Thanks again for joining us today on the Prostate Health Podcast. Now, do you have an upcoming appointment at the urologist office? Maybe you're scheduled for a biopsy of your prostate or just received the news that your biopsy was positive for prostate cancer and now have an upcoming consultation to discuss options with your urologist. You may be wondering, how should I prepare for these appointments and what should I expect? Well, I've partnered with the Prostate Health Academy to create a free What to Expect guide that will help get you up to speed as you prepare for your visits. This guide includes checklists of what you need to bring and how to prepare. This guide includes what to expect with 3 different scenarios, including your initial urology clinic appointment, a prostate biopsy, and prostate cancer consultation. To receive this free guide, simply go to www.prostatehealthpodcast.com prostatehealthpodcast.com/clinic. Again, that's www.prostatehealthpodcast.com/clinic, or you can find the link on our podcast website at prostatehealthpodcast.com.
I was going to see if you could comment just a little bit about the concept of bladder preservation. I know you and I both see patients come in on these medications. We look in their bladder and we already start to see changes of essentially damage to the bladder, and, talk a little bit about, are these medications protective or not for some of these changes within the bladder?
Well, I'm pretty sure we have evidence that they don't do that. Mm-hmm. What is interesting is that we haven't really been able to accurately measure the course of time and the impact of BPH on, there's no longitudinal study that really gets to the point that you're beginning to make. And yet in urology, we know for certain that a guy can be on a pill, one of these great drugs, and 10 years in, he develops urinary retention, several liters in his bladder. By this time, the bladder has been permanently damaged. And had we been a little more attentive earlier on, or not just us, our patients haven't wanted a TURP. We were caught in a zone where we knew drugs weren't ideal, but they were what patients preferred. And yet, in the small studies that we do have to look at, these drug therapies do not protect against bladder decay. They make people feel better, but they don't protect the bladder from its ultimate demise. And as urologists, we talk a lot about the prostate. What we're really thinking about is preserving and protecting the bladder.
Yeah. Now, certainly as urologists are becoming more aware that these medications may not be protecting the bladder health, many have been in search of a more minimally invasive approach to relieve the obstruction. What has been your experience with some of these various approaches over the years?
Yeah, well, and some of it I observed and never got fully intrigued by, but early on, just like, thinking the way cardiologists think, well, let's stretch the prostate with a balloon. And that was a dismal failure. It may have worked for the first several days, but it really always failed. Let's put a stent inside the prostate. So there was a little wire basket that was deployed called the UroLift stent. Well, it turns out that metal in the urethra is a bad idea, and universally these things would calcify. And now we have a basket that's not very adherent, to the lining of the prostate. It doesn't get underneath the lining tissue. Exposed to urine, it forms stones, and those stones were extremely hard to remove, and then you had to pull out the pieces of the basket. It turned out to be probably the worst of all the failures of procedures. Heat was used in a couple of different ways. This is all in the early 2000s. The microwave generator was through a catheter. Then there's also a radio frequency generator, just different forms of heat, and that was delivered through a needle. And both of those procedures, honestly, of the ones we've just discussed, they're still out there. There are some urologists who believe in the radio frequency procedure called TUNA and the microwave procedure that we just discussed. But in truth, very painful procedures, not a lot of durability. These things often had to be repeated. They never really created the kind of opening that we're all after. The original, investigators, the original inventors were thinking about when they carved open the prostate with a TURP. So in that sense, we had failed to achieve anything that even resembled the success that was already happening with the TURP, which, by the way, again, patients didn't want. So things have developed since that time.
Now, and you'd kind of alluded to, how some of those procedures worked, and really all of which relied on some sort of destroying, heating, removal, vaporizing normal tissue. And now we've been fortunate to have a new procedure called the UroLift system, and now entering into a new paradigm which offers really more of a mechanical solution to a mechanical problem. Again, you are the first urologist in North America to perform the UroLift procedure for BPH in 2011, and was the first in the world to perform UroLift under local anesthetic in the clinic setting. Can you tell us a bit more about the UroLift system?
Sure. It's a little hard to conceptualize without images, but let's just give it our best shot. The UroLift, I think, and I always feel like I offend the inventors when I say this, UroLift acts a little bit like a wall anchor that you're going to use to hang a mirror on the wall, in the sense that we've got to squeeze that wall. We have something on the inside, something on the outside. We use a screwdriver, right? We snug up that wall. And when we do so, the anchor that serves as a secure site for hanging something heavy. So thinking in that terminology, we use UroLift, which is 3 pieces. One piece that goes through the prostate and anchors on the outer surface with a capsule. Then there's a suture instead of some sort of screw, and the suture, as it's tensioned, brings the inner part of the prostate closer to the outer part of the prostate, as if we're squeezing that wall, but we make, in this case, a big defect. And we can do it on the other side. The last portion of the procedure is cutting that suture and applying one tiny piece of metal. And as delicate as this actually looks to the observer, it is remarkably reliable in its ability to distract, displace, disobstruct, and to do so without heating, burning, steaming, any of those kind of awkward sounding and painful sounding, tools.
So could you tell our listeners a little bit about, why this has been a game changer, really comparing this to some of the other options that we've had in terms of the patient experience in regards to outcomes and side effects?
So first and foremost, let's compare it to the drugs. The drugs never protected the bladder. Now we have created a defect, and we've learned over the years that, if you do a TURP surgery, you open that prostate, the bladder is protected. So in essence, without all the carving, the bleeding, etc., we've achieved something similar. So that's an important comparison. As compared to that metal basket, well, a huge difference between metal in the urethra that never get indaginated or covered over by the lining tissue and the UroLift is that UroLift every single time covers over, and the delicate lining tissue, this attention to the suture, and before you know it, in a matter of sometimes weeks, if you were to look back in, you'd never see these little pieces of metal that we talked about. And by not seeing them, neither does the urine see them. We don't see stones form as a result of that, and that's great. The other kind of current procedure that this should be compared with is the procedure called Resume. I did the first Resume in North America as part of a clinical trial as well. And just by simple patient experience, steam in the prostate, which is what Resume entails, is very painful because of the heating involved. There's always a catheter afterwards, and who knows when to remove that. And then as the heating dissipates over time, can lead to months of recovery issues. UroLift, on the other hand, mechanically obstructing, opening the channel, you see what we get. I mean, we are able to sculpt that tissue and create a defect that makes us feel good about what we did and then protects the bladder. This procedure can be done under local anesthesia. It doesn't take a long time. Patients get better quickly, mostly without a catheter, and they appreciate that. And even beyond all of those things, which are great, no sexual side effects. And this is the only way we can treat BPH without sexual side effects. None of the pills, none of the procedures, only UroLift.
And you're probably seeing this in your practice as well, that as we enter this new paradigm in the management of an enlarged prostate, urologists are now able to deprescribe rather than represcribe these medications, getting these patients off their BPH medication, and in men newly diagnosed with bothersome urinary symptoms, avoid starting medication altogether and fixing the problem rather than putting a Band-Aid on it with medication.
Yeah, we see this alike. And I think that what we as urologists have done over the years is we prescribed pills because people didn't want surgery, and we did it until the point that the bladder literally had suffered, permanent damage. What we can do is something as acceptable to patients as UroLift is we can jump in early. We can preserve bladder function. We don't even have to expose them, as you just said, to some of these medications and the side effects that we've just barely brushed on. I mean, there's more to the side effects of these drugs than we can probably cover in this interview, but I think we are in a position to help men preserve their bladder function long-term by intervening earlier before the bladder has suffered serious and permanent damage.
Well, this has been wonderful. So in summary, men are really able to benefit from this new shift in the treatment of an enlarged prostate. For those that have been on prostate medication, now able to come off the medication or maybe avoid it altogether with a minimally invasive option like the UroLift procedure, which offers a mechanical solution to a mechanical problem. Dr. Gange, any final thoughts for our listeners regarding this new kind of shift in the treatment of BPH?
Well, none of this happens if we don't see the patients. And men in general are reluctant consumers of healthcare. And so what we are beginning to see is because we've offered a mechanical solution to a mechanical problem, these generally mechanically minded guys are drawn in earlier. And frankly, we start prescribing these pills, and I think we're looking at a different generation of consumer. People are not putting up with the side effects that we used to think was something they should just kind of have to deal with. And so they're challenging us. As a result, we're thinking through the algorithm differently. And I'm right there with you, Dr. Pohlman. We have started to frame shift, to front load, if you will, to just intervene in a way that's so much more sensible and so much better for the long run.
Dr. Gange, it was certainly a pleasure to chat with you today on the Prostate Health Podcast. I appreciate you taking time out of your schedule to visit with us, as you've given tremendous value to our listeners, which will really help empower them to help increase their quality of life and overall health. Thank you again.
Thank you, Garrett. Bye-bye.
Thank you again for listening to the Prostate Health Podcast. Follow me on Twitter and Instagram at GPohlmanMD. Don't forget to join us next week for another episode.